Hello, this is Dr. Richard Fleming, and today is Friday, September 11th, 2020. This is a day that I, like many of you, remember with mixed emotions and mixed responses. I remember seeing Air Force One flying into Offutt Air Force Base on this day as the country came under attack. Today, the United States and every other country in the world is under attack, and this time by a virus. We'll leave it for other video discussions to look at who's responsible and where this virus came from. More important today, I want to address two fundamental topics. First, those who may or may not have known, and secondly, treatments that doctors need to be initiating for this virus. Those of you who've been listening to this series of videotapes know that I have been reluctant to share the information obtained in our research and work until it's been published in medical journals. I'm going to break with that in just a few moments to provide some initial information that physicians taking care of patients need to know. But first, I want to turn my attention to the recent discussions about what President Trump did and did not know. It is apparent, and most of us, I think, already knew this, that President Trump knew that this virus was particularly more threatening than was initially let on. One of the responsibilities of any leader is to try to reduce the anxiety and panic that occurs in a population. Sometimes that can be done successfully, and sometimes it comes back to bite the person trying to protect. I think any of you who've been parents understand this phenomenon as you try to help your children get through life. The responsibilities of leaders is not significantly different. This is not to say that the method that played out was perhaps the best approach, but it is nonetheless the one that happened. What you need to ask yourself if you're going to criticize people is, do you honestly think that President Trump was the only one who knew this information? When Doctors Fauci, Birx, Adams, Redfield, Hahn, and Mr. Azar stood up at the podium and told everybody there wasn't anything to worry about. If you're criticizing the president for his responses, you may want to criticize these other individuals because they, in fact, had more legitimate scientific knowledge than the president did. The president is, after all, a politician, not a scientist and not a physician. So let me now turn my attention to the physicians and scientists. There are treatments for COVID-19 and treatments that you need to be aware of. Yesterday, I released a brief discussion on a patient that we saw that was treated for COVID-19. That patient was initially started on hydroxychloroquine and zinc by the physicians taking care of them, and it did not work. They were hospitalized and underwent FMTBDM testing and then initiated on interferon and tocilizumab, an interleukin-6 inhibitor, and responded quite well. There was a reason for releasing that as the first patient piece of information that I've given to you, and that was the introduction of interferon. Since the initiation of SARS-1 back in 2002, considerable research had been done into how that virus replicated itself. There is a gene in humans called p53. When abnormally functioning, cancers can develop. When abnormally functioning, infections can prosper. SARS and SARS-2, which you know as COVID-19, interferes with the expression of p53. As a result, the virus is able to replicate, get a foothold in people, and interfere with the immune system response in the very beginning T cell cytotoxic response that I've spoken to you about. There are two significant treatments that are known to improve the expression of p53. One of those is zinc, which has to do with the folding of the proteins from p53, making them functional. And the other one is interferon. Interferon, as I've mentioned briefly before, is initially responsible for helping the body's immune system attack the virus and to interfere with the replication of the virus. By interfering with it, the virus can't make as many copies of itself and can be more easily brought under control. However, SARS-2, COVID-19, like SARS-1, is very good at shutting down p53 and as a result, interfering with the interferon. That is where the term interferon comes from. It interferes with the replication of viruses. For those of you who are physicians treating patients in the outpatient setting who have COVID-19, I am encouraging you today to use 4 drugs in your treatment arsenal in an effort to prevent them from becoming hospitalized. Hydroxychloroquine, which interferes with the attachment of SARS via the S protein, and sialic acid receptors. It interferes with the Toll-7 receptor that promotes inflammation. It slightly increases the pH of cytosols, making it impossible or less likely for the virus to remove its capsule to start replication. It interferes with the clotting by interfering with glycoprotein 2B3A, and it enhances the introduction of zinc coming into the cells by the zinc ionophores or pathways, and that zinc interferes with the replication of the virus. The second drug is zinc, for the reason just mentioned, interfering with the replication of the virus, and because the zinc will assist in the p53 gene expression for the production of interferon. The third item is magnesium to reduce any potential issues related to hydroxychloroquine. And the fourth is interferon alpha 2 beta. The Cubans have been quite successful in this, and there's no reason why this country should not share in that. For those of you taking care of patients coming into the hospital, I encourage you to try to quantify what's really going on. If you want to use FMTVDM, please let me know, and I will work with you to make this available. In the absence of that, it's important that your treatment be focused. For that reason, and for the reasons just expressed, I would encourage you to make certain that the patients are receiving interferon, zinc, preferably if they haven't already received hydroxychloroquine or a similar compound to reduce viral replication and attachment, to try to address that. But by the time they are hospitalized, you are now dealing with an immunologic response. You need to be treating them with interferon. You need to be treating them with tocilizumab, an interleukin-6 inhibitor, or whatever one your hospital or facility is using. And you need to be thinking about the addition of steroids and possibly remdesivir. This is a virus not to be played around with, and more aggressive up front is going to buy valuable time days later. Patients that must receive additional treatment for oxygenation because of the difficulty breathing should be addressed by initially placing them on their stomach, the prone position, and carefully looking at alternatives for oxygenation, with the last option being ventilators. Not only do patients require more of your time and treatment attention, but there's no indication that it's necessarily producing better outcomes. And if you place a COVID patient with ARDS on a ventilator, the fluid accumulation from the inflammation responding to the virus, you will need to reduce the tidal volume, and that will probably require that you paralyze them so they don't overbreathe the ventilator. You should be checking blood tests to look for cytokine release, evidence of increased blood clotting, which should at least initially be treated by sub-Q heparin to reduce the formation of the blood clots that are killing these patients. You don't have days to play around with this. You need to be treating them immediately. You can use FMTBDM to monitor treatment progress every 3 days, which is the amount of time required not for FMTBDM, but for the drugs to take effect. If you have a patient that is 7 to 10 days out from their infection, they will begin to form some type of antibody response. That antibody response, while almost always thought of as a positive, can also be a two-edged sword, because on the Fc receptor of the antibodies is the complement cascade attachment, and that will increase the blood clotting tendency in these patients, interfering further with the ability to get oxygen into the patient via pulmonary emboli, as well as producing other blood clots, which can produce neurologic damage, heart damage, and damage elsewhere throughout the body. This is September 11th, and this is actually a good September 11th, because now you are aware of the treatment protocols that I have been recommending. The decision is up to you whether you use them or not, but it is now on the record that you should be using these. As we think about this day, as we think about what happened 19 years ago, as we think about the interference of medical practice by politicians, attorneys, courts, governors, we are in the same scenario that the physicians found themselves in the late 1930s in Germany. We have to make some decisions. We have to decide whether we are going to put the patient first or ourselves. The problem with putting ourselves first may be that it's the easy way to go, and we think that that will allow us to keep our jobs and our medical licenses and our income. I think what we've seen in this country already has demonstrated that when we are no longer useful, we will be cast aside in the medical community, as hospital administrators and people in power no longer consider us necessary or viable. The only way that we're going to take control of this virus is to take control of the treatment of our patients, ourselves as physicians. And as scientists, we need to be investigating the real questions about SARS, why it's turning off the P53 system, and which medications actually work, and how rapidly we need to be initiating things. We, unlike politicians, have taken an oath to patients. We can either choose to honor that oath, or we can choose to abandon it and try to protect ourselves. There is no protection in a system that is run amok, that is being controlled by other people when patients are dying. The only options we have are to either practice medicine and protect our patients and treat them, or to abandon our oaths. Doctors, it's now up to you.